Welcome to another deep dive with us. This time we're heading straight into the world of a childhood classic.
Yeah.
You know it, acute otitis media. But we're going a bit deeper than the usual textbook overview. We're pulling some insights from the World Health Organization's AWARE guidelines,
Oh, definitely.
specifically their chapter on antibiotics,
Mm.
to give you as medical microbiologist a really nuanced perspective on this common infection.
Yeah, I mean, it's a condition we might think we know inside and out, but,
Yeah,
there's always more to learn, especially when it comes to, actually putting the latest guidance into practice.
exactly. So let's start with a little refresher. When we say acute otitis media or AOM, what are we actually talking about and what makes it like the VIP of pediatric clinics?
Okay, so at its core, AOM is an infection of the middle ear.
Yeah.
And you're totally right. It's super common in young children, especially under 5. And a big part of that is just anatomy. If you think about a child's eustachian tube, that little channel that connects the middle ear to the back of the throat, it's shorter and positioned way more horizontally than in adults, which makes it so much easier for fluids and pathogens to get stuck in there. Add to that the fact that their immune systems are still under construction and they're constantly swapping germs in places like daycare.
Oh, yeah, for sure.
And you've got a breeding ground for ear infections.
It's like their ears are just set up for it in a way. So when a child comes in, what are those signs, like those classic things that make you think, okay, maybe this is AOM?
The trifecta is ear pain, fever, and they're just super irritable.
Yeah.
The ear pain can be really sudden and severe, so they're distressed.
Right.
And sometimes you see discharge from the ear if the eardrum has ruptured,
Right.
which I know can freak parents out, but it often actually relieves the pain a bit.
That makes sense.
Yeah.
But we can't diagnose on symptoms alone. So where does otoscopy fit in? How crucial is it?
It's absolutely essential. You have to do it. It lets us see the tympanic membrane and look for those signs that it's inflamed. So in AOM, it'll look bulging red and it might even look opaque. You'll also notice that it doesn't move as much, and we check that with pneumatic otoscopy.
So we're looking for that classic angry eardrum. Now let's talk about lab tests. Are they always necessary to really lock in that AOM diagnosis?
That's a great question, and this is where the AWARE guidelines really come in handy. For those straightforward, uncomplicated AOM cases, routine microbiological testing isn't usually needed.
Okay.
Even if the eardrum is perforated and you see discharged cultures from that fluid shouldn't be the main thing driving our treatment choices.
Interesting. So we're not jumping to get a culture every time. What about other lab tests like blood work? When are those a good idea?
Again, the AWARE guidelines are pretty clear on this. You don't routinely need them for uncomplicated AOM. We would typically reserve those for cases where we're worried about complications like mastoiditis, or if the child just seems really sick overall and we need to rule out other serious infections.
Okay, so it's about being really focused with those tests and only using them in specific situations. And the WHO seems to agree with that when it comes to microbiology tests too.
Absolutely. They specifically say routine microbiology tests aren't recommended unless there's a concern about complications or if the initial treatment doesn't work.
So careful observation and a targeted approach to testing seems to be the message here. Now, what about imaging? Is a CT scan ever part of the initial workup?
Like with the lab tests, we wouldn't go straight to imaging. A CT scan is only considered if we think there might be a complication, like mastoiditis or even a brain abscess,
Yeah.
or if the child's just not responding to treatment the way we'd expect.
It's all about trying to avoid unnecessary interventions, right? Which fits right in with good antimicrobial stewardship.
Exactly. It's about using our resources wisely and not putting kids through tests and treatments they don't actually need.
Now let's get to the part that everyone always wants to talk about. Treatment. And it's interesting how the approach to managing AOM has really changed over time.
Oh, for sure. And the AWARE guidelines give us a great framework for making evidence-based decisions when it comes to treating AOM, especially with antibiotics.
And I gotta admit, I was kind of surprised to learn that antibiotics aren't always the first line of defense.
Yeah, I think a lot of people are surprised by that. But the idea of watchful waiting has gained a lot of traction, especially for kids over 2 who have mild or moderate AOM.
It does seem counterintuitive at first, but I'm curious to hear more about the why behind it. How do we decide when it's appropriate, and what does watchful waiting actually involve?
Well, watchful waiting basically acknowledges that AOM, especially in older kids, often clears up on its own without antibiotics.
Okay.
The immune system is amazing, and a lot of times it can handle the infection without us jumping in.
So it's like we're giving their bodies a chance to fight it off naturally. But how do we figure out which kids are good candidates for this?
The AWARE guidelines have a few factors to consider. Age is a big one. Like we said, kids over 2 tend to do better without starting antibiotics right away. How severe their symptoms are is also important.
Right.
So if a child has a mild fever and their pain is manageable, watchful waiting might be a good option. But if they're super uncomfortable, have a high fever, or just look really sick overall, then we'd probably start antibiotics right away.
So it's a judgment call based on the individual child. But what does watchful waiting actually look like? Are we just sending them home and crossing our fingers?
Definitely not. It's called watchful waiting for a reason.
Okay.
We monitor them really closely and give them supportive care to manage the discomfort. So things like over-the-counter pain relievers like acetaminophen or ibuprofen, as well as ways to help with nasal congestion. And the AWARE guidelines actually give specific dosing recommendations for these meds,
Oh, that's helpful.
which can be really useful for both us and the parents.
Yeah, having those clear guidelines can take away some of the guesswork, especially for parents who are obviously worried. But what if watchful waiting doesn't work? What are the signs that we need to step in with antibiotics?
We're always looking for those warning signs. If their symptoms get worse or don't improve after 48 to 72 hours of watchful waiting, that's a sign that we need to start antibiotics.
Yeah.
Same thing if new symptoms show up like a worsening fever, ear pain gets worse, or there are signs that the infection is spreading.
So we're not just sitting back and watching, we're actively evaluating the situation.
Yeah.
Now, let's say we do decide antibiotics are needed. The AWARE guidelines recommend amoxicillin as the first choice. Why is that?
Well, amoxicillin has a lot going for it. First, it's effective against the most common bacteria that cause AOM, like Streptococcus pneumonia and Haemophilus influenza. Second, it's generally well tolerated.
Right.
So not a lot of side effects. And third, it's easy to get and it's affordable in most parts of the world.
So it ticks all the boxes. The guidelines even give us specific doses broken down by weight bands for kids. Can you explain what weight bands are and why they matter here?
Sure. Weight bands are basically ranges of weight that help us decide the right dose of a medication for a child. They're important because kids process drugs differently than adults, and their weight plays a big part in that.
Yeah.
Using weight bands makes sure we're giving a safe and effective dose and not underdosing or overdosing.
So it's all about really personalizing the treatment for each child.
Yeah.
But what if a child can't take penicillin? What are our options then?
That happens a lot, and the AWARE guidelines have alternatives for those cases. For kids with non-type 1 hypersensitivity reactions to penicillin, we can use things like cefuroxime acetyl or ceftriaxone. And for those with type 1 hypersensitivity, which is a more serious allergic reaction, we can consider macrolides like azithromycin or clarithromycin.
Okay.
Although we do have to keep in mind that macrolide resistance is increasing.
So we've got backup plans ready for those who can't handle amoxicillin. Now, let's say we've started a child on amoxicillin. How long is the typical treatment?
The standard is 5 days.
Okay.
And this is where the guidelines get really interesting. They actually explain the thinking behind that specific time frame.
I like that.
You know, it's about balancing how well it works with minimizing the risk of antibiotic resistance.
That's what I love about these guidelines. They're not just telling us what to do, they're explaining the why. So what's the rationale for 5 days?
Well, our studies have shown that shorter courses, like 3 days, aren't as good at wiping out the infection, especially in younger kids. But longer courses, like 10 days, don't really give you any extra benefit over 5 days, and they actually increase the risk of side effects and antibiotic resistance.
Makes sense.
So 5 days seems to be the sweet spot where we get the best results with the fewest risks.
It's amazing how research helps us refine these treatment strategies. Now, we've talked about all the practical stuff, but I want to dig a bit deeper into the pathophysiology. What's actually going on in the ear during an infection?
Okay, so let's picture what happens. It usually starts with a viral upper respiratory infection, which, as we know, is super common in little kids. These viruses, like rhinovirus or RSV, cause inflammation in the nasopharynx.
Okay.
So that's the area at the back of the nose and throat.
So the virus is setting the stage for problems.
Exactly. And that inflammation can spread to the eustachian tube, which makes it swell up and get blocked. Fluid starts building up in the middle ear, and that creates this warm, moist environment that bacteria just love.
So it's like the virus creates this perfect little vulnerability, and then bacteria are like, let's go.
Yeah.
But aren't there already bacteria hanging out in the nasopharynx anyway? Why do they suddenly become an issue?
Great question. You're right. Our nasopharynx has a whole community of bacteria living there, but most of them are harmless or even helpful. But when the middle ear gets inflamed and filled with fluid, the whole balance changes. These normally friendly bacteria can suddenly multiply like crazy, and that's when you get a full-blown bacterial infection.
It's like the environment shifts and these bacteria go from good neighbors to party crashers.
Exactly. And once they take over, they release stuff that irritates the middle ear even more, causing more inflammation, pain, and pressure. And that's when we see those classic AOM symptoms.
It's like a vicious cycle. Inflammation feeds the bacteria, and the bacteria make more inflammation. Now let's zoom out and talk about AOM globally. We know it's common, but how big of a problem are we talking about?
AOM is a serious global health issue. It affects millions of kids worldwide. In 2017, there were something like 317 million cases globally, and a lot of these cases are in low and middle income countries where access to healthcare is limited.
That's a huge number. What happens when AOM goes untreated in these resource-limited settings?
It can have really bad consequences. Sometimes it can turn into chronic suppurative otitis media, which is a long-term infection that can lead to hearing loss, language delays, and even problems learning.
It really shows how something that might seem relatively minor in a well-resourced setting can have a huge impact on a child's life elsewhere.
Definitely. And it highlights the importance of global health initiatives that focus on making healthcare more accessible and promoting early detection and treatment of AOM.
Okay, now we can't talk about AOM without mentioning the usual suspects, the microbes behind this common infection. Who are the main players, and what do they do in the whole disease process?
Well, we've talked about how AOM often starts with a viral infection, and those viruses are the main triggers in most cases.
Right.
Respiratory syncytial virus, or RSV rhinovirus, and human metapneumovirus are some of the most frequent culprits, especially in young children.
So those viruses get the ball rolling, setting the stage for a bacterial superinfection.
Exactly. And when the bacteria join in, the usual suspects are Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
Okay.
These bacteria are usually already hanging out in the nasopharynx, but like we talked about earlier, they can become a problem when the middle ear gets inflamed and filled with fluid.
It's fascinating how those seemingly harmless bacteria can turn into troublemakers when the environment changes.
It's all about balance.
Yeah.
And understanding how these microbes interact is so important for managing AOM effectively.
We've covered a ton of information already, from what AOM actually is to the ins and outs of treatment and that complex relationship between viruses and bacteria. I'm feeling pretty good about my AOM knowledge now.
Me too.
Yeah.
Are you ready to put that knowledge to the test? I've got some exam-style questions that'll really make you think.
Let's do it. Bring it on.
All right, let's fire up those brain cells and tackle some exam-style questions. I've got some real head-scratchers ready.
Okay.
Get those thinking caps on.
First one. Picture this. A 3-year-old patient comes in with fever and ear pain. What's the absolute must-do for a definitive diagnosis?
All right, this one's straight from the basics. We're talking otoscopy. Got to get a good look at that tympanic membrane and see if it's all red and angry. That's our visual confirmation of acute otitis media.
You got it. Can't skip that step. Okay, next scenario. A 1-year-old has bilateral acute otitis media. How would you manage this little one?
This is where those special considerations come in. Remember we talked about those red flags? Bilateral AOM in a child under 2 is a big one. We wouldn't even consider watchful waiting here.
Right.
Antibiotics are the way to go in this case, even if their symptoms aren't super bad.
You got to protect those little ones. All right, switching gears a bit. A 4-year-old comes in with mild ear pain, a little bit of fever, but they're otherwise happy and playful. Do we jump straight to the prescription pad?
This is where our understanding of watchful waiting is so important. This child is over 2, their symptoms are mild, they're a great candidate for observation and just supportive care. We'd watch them closely, of course, but antibiotics wouldn't be our first move.
Love it. Judicious use of antibiotics is so key. Okay, next question. If we decide antibiotics are needed, what's our go-to choice for acute otitis media according to the AWARE guidelines?
Amoxicillin is our star player. Effective, well-tolerated, easy to get.
Yeah.
It's first line for a reason.
Right on. All right, last question, but definitely not the least important. What are some key things we can do to try and prevent acute otitis media in the first place?
This is where we got to think big picture. Preventing those upper respiratory infections is crucial. Good hand hygiene is a must. And don't forget about the power of vaccination.
Right.
Vaccines against Streptococcus pneumonia, Haemophilus influenza type B, and even influenza can really help protect those little ears.
Excellent points. Prevention is always the best medicine. This deep dive has been so insightful. We've really gone beyond just a surface-level understanding of acute otitis media.
I agree. We've broken down the microbiology, the epidemiology, the treatment guidelines, and even tested ourselves with those exam questions, and it all comes back to those AWARE guidelines. They're such a valuable tool for staying up to date on how to best manage this common childhood infection.
Absolutely. The AWARE guidelines give us evidence-based recommendations that help us make informed decisions for our patients. But I think what's really stood out to me is the focus on a targeted approach. We're not just treating every single case of AOM with antibiotics.
Right.
We're really looking at each child, thinking about their individual risk factors and tailoring our management accordingly.
That's the beauty of it. It's about personalized medicine, finding that balance between effective treatment and minimizing unnecessary interventions.
Well said. And you know what else has stuck with me? That concept of watchful waiting. It's such a powerful tool that lets us use the body's natural defenses while still being ready to step in if we need to.
It's about respecting the immune system and understanding that sometimes the best thing we can do is observe and support rather than jumping to aggressive treatment.
And I think that's a great takeaway for our listeners. Sometimes less is more. And when it comes to acute otitis media, watchful waiting can be a real game changer.
Well said. And on that note, a huge thank you to our listeners for joining us on this deep dive into the world of acute otitis media. We hope you found it informative and engaging.
Keep those minds curious and remember, knowledge is our most powerful weapon in the fight against infectious diseases. Until next time, stay well and keep exploring the fascinating world of medical microbiology.
It's acknowledging that AOM, especially in older kids, often just clears up on its own,
Yeah.
without antibiotics.
Right.
The immune system is pretty amazing.
Yeah.
And in a lot of cases, it can handle the infection without us needing to jump in.
So we're giving their bodies a chance to fight it off naturally. But how do we know which kids are good candidates for watchful waiting?
The AWARE guidelines actually lay out some factors to consider. Age is a big one.
Yeah.
Like we said, kids over 2 tend to do better without starting antibiotics immediately.
Right.
And then the severity of their symptoms is important too.
Okay.
So if they have a mild fever and their pain's manageable, watchful waiting might be the way to go. But if they're really uncomfortable, have a high fever, or just seem super sick overall, then we'd probably go ahead and start antibiotics right away.
So it really depends on the individual child and their situation. But what does watchful waiting actually look like in practice? I mean, are we literally just sending them home and saying, hope for the best?
Oh, no, not at all. It's called watchful waiting for a reason. We're keeping a close eye on them and giving them supportive care to manage their discomfort. So that might mean things like over-the-counter pain relievers like acetaminophen or ibuprofen, and things to help with nasal congestion. And the AWARE guidelines even give specific dosing recommendations for these medications.
Oh, wow.
Which can be super helpful for us and for the parents.
Right, because having those clear guidelines takes out some of the guesswork, especially for parents who are already worried. But what happens if watchful waiting doesn't work? What are the signs that we need to start thinking about antibiotics?
We're always watching for those red flags. So if their symptoms get worse or don't improve after like 48 to 72 hours of watchful waiting, that's definitely a sign that they need antibiotics.
Oh.
Same thing if new symptoms pop up.
Right.
Like their fever gets worse, their ear pain gets worse, or we see signs that the infection is spreading.
So we're not just passively observing. We're actively assessing what's happening. Now, let's say we do decide to go with antibiotics. The AWARE guidelines recommend amoxicillin as the first-line choice.
Yeah.
Why is that the preferred option?
Amoxicillin's got a few things going for it. First of all, it works against the most common bacteria that cause AOM, like Streptococcus pneumonia and Haemophilus influenza.
Right.
Second, it's usually well tolerated.
Yeah, okay.
So not a lot of side effects. And third, it's pretty easy to get and affordable in most parts of the world.
So it covers all the bases. The guidelines even break down the doses by weight bands for kids. Can you explain what weight bands are and why they're important?
Sure. Weight bands are basically ranges of weight that help us figure out the correct dose of a medication for a child.
Okay.
And they're important because children metabolize drugs differently than adults do.
Right.
And their weight plays a big role in that.
Yeah.
So using weight bands helps us make sure we're giving them a safe and effective dose and not too much or too little.
So it's all about tailoring the treatment to each individual child. But what if a child is allergic to penicillin? What are our options then?
That's a pretty common situation, and the AWARE guidelines do give us some alternatives. For kids who have non-type 1 hypersensitivity reactions to penicillin, we can use things like cefuroxime or ceftriaxone.
Okay.
And for those with type 1 hypersensitivity, which is a more serious allergic reaction, we can consider macrolides like azithromycin or clarithromycin. But we do need to be aware that macrolide resistance is on the rise.
So we have backup plans for the kids who can't tolerate amoxicillin. Now, let's say we've started a child on amoxicillin. What's the typical length of treatment?
The standard is 5 days.
5 days.
And this is where the guidelines get really interesting. They actually explain the reasoning behind that specific time frame.
I like that.
It's about balancing effectiveness with minimizing the risk of antibiotic resistance.
I love that about these guidelines. They don't just tell us what to do, they explain the why. So why 5 days?
Well, research has shown that shorter courses, like 3 days, just aren't as good at completely getting rid of the infection, especially in younger kids. But longer courses, like 10 days, don't give you any more benefit than 5 days. And they increase the risk of side effects and antibiotic resistance.
So 5 days is kind of that sweet spot.
Exactly. It seems to be that sweet spot where we get the best results with the least risk.
It's really amazing how research helps us fine-tune these treatment approaches. We've talked a lot about the practical aspects of managing AOM, but I'm curious about the pathophysiology. What's actually going on inside the ear during an infection?
Okay, so let's break it down. It usually starts with a viral upper respiratory infection, which we know is super common in little kids. These viruses, like rhinovirus or RSV, cause inflammation in the nasopharynx. That's the area at the back of the nose and throat.
So the virus is kind of setting the stage for trouble.
Right. And that inflammation can spread to the eustachian tube, which causes it to swell up and get blocked. And then fluid starts building up in the middle ear. Right. And that creates a nice, warm, moist environment that bacteria just love.
So it's like the virus creates this perfect little opportunity, and the bacteria are like, party time.
Exactly.
But hold on. Aren't there already bacteria hanging out in the nasopharynx anyway?
Yeah.
Why do they suddenly become a problem?
That's a great question. You're right. Our nasopharynx has a whole bunch of bacteria living there, but most of them are either harmless or even helpful. But when the middle ear gets inflamed and filled with fluid, the whole balance changes. And those normally chill bacteria can suddenly multiply like crazy. And that's when you get a full-blown bacterial infection.
It's like the environment suddenly shifts, and these bacteria go from being good neighbors to being total party crashers.
Exactly. And once they're in charge, they start releasing things that irritate the middle ear even more.
Right.
And that causes even more inflammation, pain, and pressure. And that's when we start to see those classic AOM symptoms.
It's like a vicious cycle. The inflammation helps the bacteria grow, and the bacteria make more inflammation. Now, let's zoom out a little bit and talk about AOM on a global scale. We know it's common, but how big of a problem is it worldwide?
AOM is a major global health concern. It affects millions and millions of children all over the world. In 2017, there were an estimated 317 million cases globally.
Wow.
And sadly, a lot of these cases are in low and middle income countries where access to healthcare is limited.
What are the consequences of untreated AOM in those resource-limited settings?
Untreated AOM can have some really serious consequences. In some cases, it can progress to chronic suppurative otitis media.
Oh, wow.
Which is a long-term infection that can lead to hearing loss, language delays, and even learning difficulties.
It really puts things in perspective.
Yeah.
Something that might seem relatively minor in a well-resourced setting can have such a huge impact on a child's life in other parts of the world.
Absolutely. It highlights how important global health initiatives are, especially those aimed at improving access to care and promoting early detection and treatment of AOM.
Okay, we can't talk about AOM without talking about the usual suspects.
Yeah.
The microbes that cause it. Who are the main players, and what role do they play in the whole disease process?
Well, like we've mentioned, AOM often starts with a viral infection, and those viruses are usually the main triggers.
Right.
Respiratory syncytial virus, or RSV rhinovirus, and human metapneumovirus are some of the most common culprits, especially in young children.
So the viruses kick things off and then set the stage for a bacterial superinfection.
Exactly. And when the bacteria join the party, the usual suspects are Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
Okay.
Those bacteria are often already present in the nasopharynx, but like we talked about earlier, they can become a problem when the middle ear gets inflamed and filled with fluid.
It's wild how those seemingly harmless bacteria can turn into troublemakers when the environment changes.
It's a delicate balance, and understanding how these microbes interact is really key to managing AOM effectively.
We've covered a ton of information already, from what AOM even is to all the details of treatment and that whole interplay between viruses and bacteria, I feel like I've really leveled up my AOM knowledge.
Me too. Are you ready to put all that knowledge to the test? I've got some exam-style questions that'll really challenge your understanding.
Bring it on. I'm ready for the challenge.
Okay, let's do it. Hit me with those questions.
All right, question number 1. Imagine a 3-year-old comes in with fever and ear pain. What's the absolute essential step for a definitive diagnosis?
Okay, so we've got a 3-year-old fever, ear pain. The most important thing for a definitive diagnosis, I'm thinking it's got to be a toscopy, right?
You nailed it. We got to see that tympanic membrane. Make sure it's looking angry and inflamed. That's our visual confirmation of acute otitis media.
Makes sense. You can't skip that step. All right, what's next?
Okay, next one. A 1-year-old has bilateral acute otitis media. How would you manage this little one? Okay, so we've got a younger patient now, and it's bilateral. I remember we talked about those red flags. Bilateral AOM in a child under 2 is a big one. So I don't think we'd mess around with watchful waiting here.
Sure.
I'd say antibiotics are the standard of care, even if the symptoms aren't too severe.
Exactly. Got to protect those little ones. All right, next scenario. A 4-year-old comes in with some mild ear pain, a low-grade fever, but otherwise seems happy and playful. Do we go straight for the antibiotics?
Okay, so this one's a little different. Older child, mild symptoms, and they're acting fine. This seems like a perfect case for watchful waiting. We'd definitely keep a close eye on them, but I don't think we'd jump to antibiotics right away.
You're getting it. Judicious use of antibiotics is so important. All right, 7. Next question. Let's say we at DO decide antibiotics are the way to go. What's our first choice for acute otitis media according to those AWARE guidelines?
Okay, if we're going with antibiotics for AOM, it's amoxicillin, right?
Bingo, amoxicillin is our go-to. Effective, well-tolerated, easy to get. It's the first-line choice for a reason.
All right, last one. What are some of the most important things we can do to prevent acute otitis media in the first place?
This is where we got to think big picture.
Right.
Preventing those upper respiratory tract infections is key. So things like good hand hygiene are super important. And of course, we can't forget about vaccines. Vaccines against Streptococcus pneumonia, Haemophilus influenza type B, and even influenza can really help protect those little ears.
Those are all excellent points. Prevention is always the best medicine. This deep dive has been incredibly informative. I feel like we've really gone beyond just a basic understanding of acute otitis media.
I agree. We've really dug into the microbiology, the epidemiology, the treatment guidelines, even tested our knowledge with those exam questions. And it all comes back to those AWARE guidelines, such a valuable resource for staying up to date on how to best manage this common childhood infection.
Absolutely. The AWARE guidelines give us those evidence-based recommendations we need to make good decisions for our patients. But one of the things that's really stuck with me is this idea of a targeted approach. We're not just throwing antibiotics at every case of AOM. We're really taking the time to look at each individual child, consider their specific risk factors, and then tailor our management accordingly.
That's what it's all about, right? Personalized medicine, finding that balance between giving effective treatment and avoiding unnecessary interventions.
I couldn't have said it better myself. And you know something else that's really resonated with me? That whole concept of watchful waiting. It's such a powerful tool. It lets us harness the power of the body's natural defenses while still being prepared to step in if we need to.
Absolutely. It's about respecting the immune system and understanding that sometimes the best approach is to just observe and support rather than jumping in with aggressive treatments right away.
And I think that's a great takeaway for our listeners today. Sometimes less is more, and when it comes to acute otitis, media watchful waiting can really make a difference.
Couldn't agree more. And with that, a huge thank you to everyone for joining us on this deep dive into the world of acute otitis media. We hope you learned a lot and had some fun along the way.
Keep those minds curious, and remember, knowledge is our greatest weapon in the fight against infectious diseases. Until next time, stay healthy and keep exploring the amazing world of medical microbiology.